Hello, everyone. Thank you for joining the Scleroderma Foundation Rocky Mountain Chapter's Virtual University. This session is titled Taking Charge of Your Lung Health. I'm Tammy Schell. I am a member of your board, and I also have scleroderma. Before we get started, I want to first thank our Executive Director, Maria, and her staff, Christine. Without their hard work, we wouldn't be having this. Just a couple quick notes about the session. If you want to ask a question, please use the chat function. I will be monitoring the chat and will collect questions for the speaker. The session is being recorded and will be made available after the broadcast. The Scleroderma Foundation in no way endorses any clinical trials, treatments, or studies mentioned in this session because the manifestations and severity of scleroderma vary among individuals. Personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with your individual doctor. This webinar is for educational purposes only. I would like to introduce to you Dr. Bull and Dr. Griffith. Dr. Bull graduated from the University of Colorado Denver School of Medicine and completed his residency at the University of Texas Southwestern Medical School. After completing a fellowship at the University of Colorado, Dr. Bull joined the Pulmonary Vascular Disease team. He divides his time between the outpatient clinic, inpatient wards, the cardiac catheterization laboratory, and the medical intensive care unit. Dr. Bull works in the research laboratory focused on developing better means of diagnosing and treating patients with pulmonary hypertension. He is involved in a number of clinical trials investigating novel therapeutic agents in the treatment of PAH and pulmonary embolism. Our second speaker is Dr. Griffith. She was born in San Francisco, California, and raised in Atlanta, Georgia. She went to college at the University of Notre Dame, majoring in biology and Spanish. Dr. Griffith attended Medical College of Georgia for medical school, where she was inducted to the Alpha Omega Alpha Medical Honor Society. She attended University of Colorado for internal medicine training and completed a fellowship in rheumatology. She was attracted to rheumatology due to her love of long-term relationships with patients and taking care of patients with medical complexity. Dr. Griffith's interest and expertise includes how to diagnose and treat autoimmune conditions that affect the lungs. Dr. Griffith was attracted to working in a scleroderma clinic due to her own family member with scleroderma lung disease. She works at the Center for Lung and Breathing Autoimmune Eye Clinic and Rheumatology Department at the University of Colorado. Dr. Bull, if you would please start your presentation.
Certainly, and Tammy, thank you for that kind introduction, and Maria, thank you very much for the invitation to present at this conference today. I'm honored to be here with Melissa, talking about an area of great clinical importance and investigative importance to both of us here at this time. I will apologize up front if a sleepy daughter of mine wanders back behind me on the camera when we're doing the presentations. They've been told that I'm doing a talk, but it was early when I told them, so we'll see if that holds when we walk through. But I think everyone's getting used to these Zoom presentations and the unpredictability about what's going to happen during the presentation. So without further ado, let me jump into this. So I am charged today to talk about pulmonary arterial hypertension and scleroderma. One of my main roles or big roles at the university is working on that from a research standpoint. I also, however, oversee our Center for Lungs and Breathing, of which both Melissa and I work in as well. That involves essentially what we've broken any and all lung and breathing diseases into various pillars that we can then deal with. These range from, a very complicated lung transplant all the way to the sort of simpler for cough, chronic cough, things along those lines. And two of the pillars that we're going to be doing today are the advanced lung disease pillar, where Melissa spends her time or part of her time from an interstitial lung disease standpoint, or diseases that that affect the lung parenchyma. And then where I spend my both clinical and research time is in the pulmonary vascular pillar. And so what I'm going to be talking about today is, again, the importance of pulmonary hypertension in scleroderma disease state. And it does play at both those disease entities, interstitial lung disease and pulmonary hypertension, are incredibly important comorbidities with scleroderma, and areas, again, we're very focused on from a treatment and investigative standpoint. So to not make this too basic, but let's start at the beginning, if we will. So this is Lung Physiology 101 here at this point. And so here we see essentially a cartoon or drawing of the respiratory system, starting with the nasal cavity going down to the trachea to the lungs. And really the part that we're going to be particularly focused on today from the lung standpoint breaks into both the conducting zone of the lungs. The lung can be thought of in two sort of general roles, if you will. The conducting system, is essentially the pipe or tubing to take gas, that being the oxygen, the ambient air in, and then waste gas out, carbon dioxide, etc. And then that then branches into the respiratory zone, which is then really made of the respiratory bronchioles, the very small tubules, to the alveoli, which I think all of us are familiar with, but really a beautiful, elegant system, 8 million alveoli, or air sacs, if you will. And this is truly where gas exchange occurs. So we can kind of think of it, and we think of diseases that affect into the lung in sort of two broad ways from that standpoint, and that's just in part how we've broken our pillars down in the CLB. So the heart, however, is the other important part of this story. And even though I'm both a lung specialist and a heart specialist, if you will, I did my training in lung, my fellowship in pulmonary and critical care, but then went on to do training in cardiovascular disease or heart disease as well, because really these are sort of beautifully integrated systems, and systems where things tend to fall apart or can fall apart in scleroderma. And so, heart physiology 101, if you will, involves, our four chambers of the heart: right atrium, which is the top part of the right side of the heart; right ventricle, bottom part; left atrium, top part of the left; and left ventricle. And really, we're going to be predominantly focused, where my work, my research is predominantly focused on the right heart. And that's kind of how subspecialized we are in medicine these days. I am a right heart doctor. I leave the left heart doctor to another group of doctors. So we divide the heart up. We divide up its electricity. We divide up its valves. We divide the heart up and all things. So most of my focus is the right heart, because it's the right heart that spends a lot of its time sort of interacting with the lungs, which we'll talk about here momentarily. And so then connecting those two entities, the lungs or the heart, are the pulmonary vasculature. And so this is sort of where I was building to. This is where the problem of pulmonary hypertension scleroderma, really begins. And so these are what we see here in red are actually the pulmonary, in blue are the pulmonary arteries, reds are actually the pulmonary veins here at this point, but we're kind of more focused on the blue at this juncture. And so this was after we deliver blood that we've done using our oxygen from the body, all that blood, from the upper extremities, lower extremities, brain, heart, etc. Once we're done with it, it dumps into the right side of the heart. The right side of the heart squeezes and sends the blood out through this vasculature, the pulmonary arteries. That then brings it to the lungs. So you can see the pulmonary arteries sort of follow the branches of the lungs. It goes down ultimately to these air sacs that we were just talking about. And then that is where gas exchange occurs. And so here's an angiogram. This is where I basically, during a right heart cath, go in and shoot dye into the pulmonary artery so we can get a closer look at what's happening there. We don't do that so much in this disease state of scleroderma. That's a different disease state we work at, but that sort of highlights the picture. But this is sort of the critical zone right here. So remember back to that respiratory zone. This is where you see the pulmonary arteries and the pulmonary veins. In this particular diagram, the pulmonary arteries are in blue because they're bringing deoxygenated blood to the alveoli. Gas exchange is occurring at the alveoli, and then that now oxygenated blood is now moving back through the red into the left heart. And this is sort of the, again, the beautiful interaction that occurs, but the critical one, and I'll just say right up front, it's in these very small blue arteries, which is where the disease state of scleroderma associated pulmonary arterial hypertension occurs. It's not so much in the big vessels coming back up, it's right sort of at these, what we call pre-capillary, right before we get to the gas exchange region of the pulmonary arteries. So now let's talk a little bit about the pulmonary vasculature. And this is, when I lecture to the medical students and the fellows and the residents, I try to really sort of bring to them my excitement, my wonder at the elegance of this system. Really a, a high capacitance, low resistance system, which means you can put a ton of blood through your pulmonary vascular bed. That is, if your heart increases in its heart rate and its ejection, bringing out more blood, you can take 4 or 5-fold increases in the cardiac output. But the pulmonary vasculature responds to that by dilating and keeping the pressure low when it is functioning normally. And this can, again, result if you're a highly trained, athlete such as, like Tour de France, you can take your cardiac output from, 5 liters per minute at baseline to close to 40 liters per minute at peak exercise. But with that, no pressure really occurs, or pressure increase occurs. And this occurs because the pulmonary vasculature, what I just showed you, can vasodilate, it can relax and let more blood go through, and it can recruit because you're not using all of your pulmonary arteries all of the time. And so it can recruit vessels that it's not using to handle extra flow. But this system, like all disease systems that we work with in medicine, can be perturbed. This is an example of a pneumonia. So this is a CAT scan. We're essentially seeing the right lung here, left lung here. All this white area is essentially a dense pneumonia. And as you can imagine, the alveoli are very affected in that area. They're not exchanging gas well. And your pulmonary arteries are actually quite smart. They can realize that there's an area that they're not exchanging gas well, and they will shut down vessels going to there, that is clamp down to keep blood from going to that area, doing something called VQ matching. So that's a physiologic thing, but when they start closing down, they can cause the pressures to rise. We see this more globally in diseases like COPD or obstructive lung disease, or we'll also, Dr. Griffith will talk about interstitial lung disease when the lung parenchyma itself is having trouble. We can see the pressures begin to rise because the oxygen is low, and so the pulmonary arteries sense this and start clamping down and cause the pressures to be high. Anyone who sat up on the top of Mount Everest for a period of time would develop pulmonary hypertension because of the low oxygen. Once again, the pulmonary arteries sensing low oxygen and cramping down and causing a pressure increase. And this is one of the reasons we'll talk about why we work so hard to get people's oxygen back to normal when we're dealing with pulmonary hypertension, because it is the normal physiology of the pulmonary arteries to cramp down when it sees low oxygen. And then this is the disease state more in scleroderma, which is a slightly different process than this hypoxia-induced pH. This is one of those, if I put my arrow on it, you can see that this is, we're cutting this lengthwise. So this is a very small artery, pulmonary artery, that I just showed you in cartoon form before, coming down and starting to branch right before we get to the alveoli, which are out here. And this is referred to right here, this lesion, as the plexiform lesion. And this is a very abnormal growth of cells that occurs right before the gas exchange in the precapillary pulmonary artery. This occurs in patients with scleroderma. It occurs in patients with other forms of pulmonary arterial hypertension. I'll show you a list of those conditions here soon. But it's this very abnormal proliferation of cells that obstruct or block the pulmonary artery and cause the pressure to rise, and then cause a problem with gas exchange and with pressure that is then transmitted back to the right heart, which is where we see the problems that occur in pulmonary hypertension. So while the disease itself is occurring in the precapillary pulmonary arteries with this plexiform lesion, it's actually a back pressure that now then impacts the right side of the heart, which gets bigger because it's trying to push against a higher pressure and eventually begins to fail unless we take that pressure off. So This is how we break pulmonary hypertension down. This is the 6th World Symposium on Pulmonary Hypertension. And essentially, we break it into 5 groups. This is a very busy slide. Don't mean to overwhelm you with this slide, but mostly just want to show how we think about pulmonary hypertension when it presents to us. And the 2 important groups from the standpoint of this talk are WHO Group 1, which we see up here, it's circled, which is broken into all these various forms: idiopathic pulmonary hypertension, heritable pulmonary hypertension, drug and toxin-induced pulmonary hypertension. That in this day and age is kind of meth-associated. Then associated pulmonary hypertension, relevant to this talk, is that associated with connective tissue disease. And so scleroderma is one of the major causes of connective tissue disease associated with pulmonary hypertension. This goes on HIV, portal, congenital, a very rare condition for this this country, schistosomiasis. And the reason we group all these kind of disparate diseases into this one classification, that is WHO Group 1, is they all have that plexiform lesion, that lesion that I was showing you before. So all these are associated with this plexiform lesion associated PH. And this is where almost all of our treatments right now, of which we have many, are focused, is in this WHO Group 1. Group 2 is pulmonary hypertension due to left heart disease. I'm not going to talk about that. Group 3 is pulmonary hypertension due to a lung process, which is something I think Melissa's going to get into here. She'll be focusing on the lung process, but anything that makes your oxygen low, like interstitial lung disease, will cause your pressures to be high. And so patients with scleroderma who get interstitial lung disease can have pulmonary hypertension due to this, or can have pulmonary hypertension due to Group 1. Group 4 is CTEPH, chronic thromboembolic PH, and Group 5 is sort of a hodgepodge of other diseases that is not as well understood. So here's that plexiform lesion again. I won't spend much time on that, but this is kind of what happens over time. So if we see this is a normal pulmonary artery cut in length, longitudinal length, this is that plexiform lesion forming over time, and we see a very abnormal proliferation of cells. This is where my laboratory has focused a lot of effort trying to figure out what those cells are, how do we measure them, that is, how do we detect when they're becoming abnormal. Ultimately, what I'll get at, this is our research goals, is how do we get that to quit and go away. And here we see sort of an end stage where it's just completely blocked the vessel here at this point. And so you can no longer see the pulmonary artery. You can see where, if you blocked off enough of these vessels, you wouldn't be able to exchange blood or bring blood to the pulmonary arteries. You'd see the pressure rise. All right. So this is our definition. Actually, this just changed in the 6th definition. Well, hasn't formally changed. There's a recommendation to change it. But the way we define pulmonary hypertension is hemodynamically. So your mean pulmonary pressure, previously greater than 25 millimeters of mercury, we're now changing that down to 20. There's a lot of controversy around that, what to do with that exactly. Your filling on the left side of the heart has to be normal, meaning your wedge pressure, which is a measurement we make during heart cath, has got to be less than 15. And then the resistance, how difficult it is to move blood through the pulmonary vasculature, has to be greater than 3, which is a calculated Wood unit. We don't have to spend much time on that. So what is our evaluation for pulmonary hypertension? We see it, well, like all things in medicine, we first start with a history. And what we're looking for in particular is that there's an underlying risk factor for pulmonary hypertension, of which scleroderma would be one. And so that's that's something then that actually gives us the opportunity to screen patients with scleroderma for pulmonary hypertension. And myself and Dr. Fisher, who used to be with us here at the university, had written a position paper on this a number of years ago, saying that we recommend yearly echoes on patients with scleroderma to try to catch pulmonary hypertension early, and I'll get to that in a minute. But our history, or we begin with history, and history in this case is, usually our history is that people just are feeling more tired than initially. They get more short of breath doing sort of day-to-day activities. That's kind of a warning sign. This is why, because that's a non-specific finding that can be a lot of different things. This is why it takes about 2 years on average, if we go out into the sort of the community, to make the diagnosis of pulmonary hypertension. If we trace back and say, when did you start really having symptoms? Those symptoms of shortness of breath usually begin about 2 years before the diagnosis was made. And so we're really kind of probing for that. As it progresses, we start seeing dizziness to even fainting. We see evidence of right heart failure with worsening lower extremity edema. Exam, of course, is critical, and we focus, specifically on the exam of lungs and heart. And when we're looking for pulmonary hypertension, in lungs, we're listening to see if we can detect anything that would point us toward that WHO group 3. In heart, we're looking for evidence of right ventricular failure. And management of that, we spend a lot of time looking at the neck. This is kind of a cheap right heart cath for us. We can get ideas of what's happening to the right side of the heart by looking at neck veins. And here we see a markedly distended internal jugular vein and external jugular vein, which is a clue to us that we've got some right heart pressure elevation. That pressure is essentially backing up to the right atrium, and we can look at that through the veins here in the neck. And then we move on to our diagnostic tests, which include lung function tests, and then echo. Echo really is, again, one of our best screening tools for it. Not a perfect screening tool, but one of our better ones. That's how we make measurements of the right heart in both size and function, and then pressure. We can get an estimate of pressure. But really, the most important aspect of this when I'm talking to other doctors is we cannot make the diagnosis of pulmonary hypertension until we go on to heart catheterization. And in a heart cath, we're essentially placing a catheter, usually through the vein in the neck, that we can go through the leg, sometimes through the arm as well, run up through the right side of the heart, up into the pulmonary arteries, and measure the pressures there. Because all these others, echo is an estimate of pressure, the cath is an exact measurement and gives us a lot of important information like severity of disease and what else we might be thinking about treating or treatment paradigms. Treatment has really been, this has been one of the great success stories in medicine. If we go back to the 1980s is when we had our first treatment, which was a difficult to use therapy of IV epoprostenol. We flash forward, we're now pushing up to sort of 18 different drugs that we can use for the treatment of pulmonary hypertension. We're experimenting on how to use them in different combinations now, and really have seen marked improvement on how patients do with this disease state. But we are constantly looking to the future and directions. And again, we are on the cusp right now, I think, of a number of important breakthroughs in the management of patients with this process. Again, this is one of the fastest moving areas, certainly in pulmonary medicine and up there in cardiovascular medicine as well. I mentioned before that combination therapy is becoming more and more important. So taking those 18 drugs and using them in different ways and in combinations is critical. And we're having a lot of success doing that, kind of borrowing from the other aspects of heart failure. But the really important thing that came back is that all of our drugs right now are vasodilators, meaning they relax the pulmonary vasculature bed. They're trying to relax things to let blood flow more easily through this plexiform lesion, if you will. But really, that's not what the disease is. Not really a vasoconstrictive disease. It's a disease of proliferation in this scenario. And so many of our drugs, our studies right now are focused on how do we get these cells that grew up here to go away. How can we get them to stop growing? How do we prevent them from growing in the first place for at-risk populations? And that's one thing about scleroderma. We know that that people with scleroderma have this as a risk. So this could be, a prevention studies could occur once we start getting these drugs to work better. We know you're at risk. We start these medications to keep this from happening. This is sort of where a lot of the excitement is right now. And this is again where my biggest hope is for the future. And then can we make these go away? And people that already have it, can we get them to regress? And, I think we're starting to see, again, studies that are really getting at this from a physiology standpoint. So with that being said, I believe I'm at the end of my 20 minutes for talking. So I am going to stop sharing. And then I think our plan was to move into questions at this phase for me. And then after that, then we're excited to hear Melissa's talk here. So.
Dr. Bull, we do have a question. Just wanting to know the difference between PH and pulmonary arterial hypertension. If you could expand upon the differences.
Yeah, so sure. So that's a great question. And so PH essentially is just a hemodynamic definition. If you say pulmonary hypertension, that previously has just meant that your mean PA pressure was greater than 25 millimeters of mercury by cath. We can estimate it by echo. And now more recently, again, there's a push to kind of drop that definition to a mean of 20. I can spend some time going into the details of why that is, but I'll say again, it's very controversial. I happen to think that's not a particularly good idea personally, but that's sort of where things right now. So PAH, pulmonary arterial hypertension, is now a specific group within that 5 groups, and so all 5 groups that I showed you in that WHO classification have PH, have pulmonary hypertension. Pulmonary arterial hypertension is only group 1. So that was that list of about 8 different diseases: idiopathic, portal pulmonary hypertension, congenital heart-associated pulmonary hypertension, toxin-induced pulmonary hypertension, and then scleroderma or connective tissue disease-associated pulmonary hypertension. Those are group PAH. And to make that diagnosis, you have to have a mean pressure greater than 25, maybe down to 20 if the new definition holds. You have to now have a left-sided filling pressure of less than 15. So when they're doing the cath, we also assess pressures on the left side of the heart. So the reason for your pulmonary hypertension can't be because you have high pressures on the left side of your heart to be in group 1. And then lastly, you have to have an elevated resistance, a pulmonary vascular resistance of greater than 3. But really, once we've made that diagnosis of PAH, you need to fit within that group 1. So you need to have one of those other conditions. And so if we don't find liver disease, scleroderma, HIV, toxin-induced, et cetera, then we call it idiopathic. It used to be called primary pulmonary hypertension or idiopathic. So does that make sense, or was I clear enough on that?
I think it does. Good to me. Now we have a question on, is it safe time to get a right heart catheterization? With the world being COVID freaked out, is it safe to have an elective diagnosis test done?
Yeah, another great question. And yeah, and so the short answer is yes. We've been up and doing them again really all summer. We sort of started again in June. We had, I think appropriately shut down around February when COVID really started rolling, and we understood COVID, or we had less of an understanding of what COVID was and did at that time. And since that time, we've learned a ton. This is my other, job as a critical care physician. So I spend a lot of time dealing with COVID, and I'm involved in a couple of big COVID research studies around clotting. And we've learned a ton about COVID between here and there. And we've learned a ton about sort of, screening and protecting individuals. And so for CAS, we do a pre-screen, meaning we, sort of similar to what you're probably used to, what we used for school, hey, were you sick, et cetera. If you've been around anyone who's in contact with, we, check the temperature. For more invasive procedures that involve the airway, we actually test before you come in. So before we do bronchs and things like that, we actually do a COVID test. And I can say so far we've had no one get sick in our cath lab, and had no transmission, from providers to patients, since the summer. So I do think we can do this safely with our screening and paying attention. We, of course, follow all recommendations, wearing masks. This is sort of one of the different things about our cath now. Our patients wear masks while we do the cath. Of course, we've always worn masks, which is, I don't want to, segue too much, but it is funny that people argue about wearing masks. I mean, physicians have been wearing masks since we figured out germ theory, back in the early 1900s. So this is not new concept that you might wear a mask to prevent transmission of disease. It's just become politicized of late. So anyway, so that was the long answer. The short answer is yes. I think it is a reasonable time. And let me just put another little, in the pulmonary hypertension world. So we also shut down clinic visits. I think people knew that initially. I think it was the right thing to do at the time. We weren't sure exactly what was going on. We didn't understand the disease state particularly well of COVID. And so we went everything to virtual. And I would say from a pulmonary hypertension standpoint, very few, I only had 2 of my patients develop COVID, and thank goodness both of them did very well. That's a kind of an interesting discussion in and of itself. Kind of what does the pulmonary vasculature, what are these meds that we use in COVID or for pulmonary hypertension? Do they do things different in COVID? That's all in theory. But we also noted a big increase in our mortality, that is death in our patient population in the pulmonary hypertension, not because of COVID, but I think, and we're trying to write this up now, because we weren't seeing patients back in clinic. And I had patients that I'd followed, personally for a number of years who had been doing very well and then hadn't been able to get to clinic visits because we moved to virtual. And then they came in much sicker, I think because we weren't seeing them on a regular basis. And while there's some value to video visits, it's not for all disease states and not for everyone, because it's hard for us. I just showed you the doctor cartoon doing exams. It's important for us to examine people and decide, do we need to bring you into the hospital to fix some of the problems that we see? And it makes me very sad to think back to patients I'd followed for years that we just hadn't gotten them back in the clinic. And by the time we got them back in, it was, too late to kind of pull them out of some of these spirals. So not only do I think right heart caths are safe, I think for some of the disease states that we're dealing with, it's important to get in and see your doctor so that we can make sure things are going okay. That was, I think, to me, an important lesson out of COVID now. And Melissa can weigh in on that in her portion as well, because I know the ILD group is very interested in getting patients in as well. So.
Dr. Bull, thank you so much for your time and answering our questions, and we will move on to Dr. Griffith.
Thank you, Jim. I appreciate it.
Thank you, guys. Sorry, I was having a lot of internet issues, so hopefully we figured this out. I got a hotspot running now. Let's see. And sharing. Can you guys see that? Okay, so I'm Melissa Griffith. Let me see. And I am new faculty at the University of Colorado in rheumatology, and I work upstairs with Dr. Joyce Lee, Dr. Bridget Graney, Dr. Yael Ashner, and Dr. Fontenot in the Interstitial Lung Disease Clinic. So today, I'm going to talk a little bit about interstitial lung disease and scleroderma. So no disclosures. And first off, I wanted to get a poll going and just see what your baseline knowledge is. Do you know what interstitial lung disease is? Yes, no, or maybe. And so we're going to launch this poll, and if you can participate, that would be great. Because we throw these words around all the time, and it's sometimes you don't even know what we're referring to. I think doctors do this a lot, and so it takes a little bit of education to really know exactly what we're talking about, because sometimes even doctors don't know what we're talking about when we say ILD. So it looks like about 52% say yes, some 7% say no, 41% say maybe. So let me have to stop sharing that and then get out of there. So what is interstitial lung disease? Well, it's lung disease that affects the interstitium. Well, that's a very broad thing again. Let me show you. Let's see if I can get a pointer. So this is, like Dr. Bull said when we was going through the anatomy, the alveoli, where gas exchange happens, is supposed to be a really thin-walled wall, and then this interstitium right here is where gas exchange actually occurs. But with disease, it can be damaged and thickened, and then you don't exchange your gas as well as you should. So your oxygen slowly moves into the blood, and then your carbon dioxide slowly moves into the alveoli, which you can imagine could cause a lot of issues. And so this is just a very broad category of lung disease that's over 200 disorders. So just saying interstitial lung disease doesn't really tell you exactly what the cause is. It's just a broad category saying we have issues with gas exchange here, and there's something wrong in between the walls of the alveoli and the blood vessel. Okay, so what are the symptoms? The symptoms are progressive shortness of breath, especially with exercise, a persistent dry cough, so that means no phlegm is coming up. That's a very common symptom. And then other symptoms depending on the cause of the interstitial lung disease. And from here on out, I'll just call it ILD for short. So what are the causes? So first off, environmental exposures. So this is particularly common in bird owners, and then there are other environmental exposures that you can be exposed to that can cause interstitial lung disease. Drugs can also do this. Infections can do it. Autoimmune or connective tissue disease, which is really where we're going to focus most of our time. Other medical conditions, and then idiopathic, which means that we don't know exactly what causes it, and this is a category in and of itself. We're going to focus on autoimmune or connective tissue disease cause now. And how do we come up with a diagnosis of interstitial lung disease or pulmonary fibrosis? Well, it takes a lot of workup. And usually people first start off with seeing either their primary care doctor, their pulmonologist, or their rheumatologist. So we start off with having with somebody who has symptoms. So they have shortness of breath and dry cough. People start off with an X-ray with their doctor, and then if that is not revealing or maybe somewhat revealing, they go on to what's called a high resolution CT of the chest, which is really helpful for us to see exactly what's going on in their lungs. They also do lung function tests, so breathing into a tube in our lung function lab. And that gives us a really good idea of how is their gas exchanging, and also how much they can breathe in and out in their volumes, and compare those to normal. So that is very helpful for us as well. They get labs done. So particularly in the autoimmune world, the labs are very important to help make a diagnosis. Sometimes they have to go in and get a procedure called a bronchoalveolar lavage. This is, they go in there into your lungs, take some fluid, and sometimes take tissue, and that's where you get the biopsy results. So it can be a very complicated and long process to figure out exactly what's going on. And we always include the heart here. Dr. Bull talked about that too, because shortness of breath can be from pulmonary hypertension, or it can be from the heart otherwise. And so we really want to make sure we know what is causing the shortness of breath. And then this takes a conversation between a lot of different specialists. So I, as a rheumatologist, am involved in this conversation frequently, as our pulmonologist, radiologist, pathologist. And we actually, here at the University of Colorado, have a multidisciplinary conference where we discuss all of our new patients, and then patients who are having different symptoms, and update presentations on those patients, so that we really have a good idea of what's going on and have different expertise in the room. So it really takes a village to make a diagnosis of interstitial lung disease and pulmonary fibrosis. Well, let's talk a little bit more. That was just a kind of broad interstitial lung disease intro, but you're here for scleroderma interstitial lung disease. So let's talk a little bit more about that. And I have another poll. So, is every person with scleroderma at risk for ILD? Yes, no, maybe. Good. So we have about, 54% say yes, 14% say no, 32% say maybe. Okay. Okay. So does ILD affect all patients with scleroderma equally? The short answer is no. All technically are at risk for having interstitial lung disease, But as rheumatologists, we break down scleroderma into two different categories. One is diffuse scleroderma, which means that the skin disease can affect above the elbow and above the knees. And then limited, which is below the elbow and below the knees for the skin involvement. And this is just a broad category saying where is the skin involved. But there are also some differences in how this ILD affects folks with diffuse versus limited scleroderma. So with diffuse, ILD tends to occur early in the course of their disease. So within a few years of having the diagnosis of scleroderma. And then more of the diffuse patients have ILD compared to the limited. So the limited scleroderma folks, it tends to actually occur late and then less frequently than it does with diffuse scleroderma. Overall, though, approximately 50 to 60% of patients with scleroderma have some form of interstitial lung disease, and that's tremendously variable from person to person, and it's really dependent on their type of disease. And then something that we as rheumatologists always think about too are the antibodies that patients have. So antibodies do matter, and they do predict what type of ILD and then what type of other symptoms that patients can get. So it's something that rheumatologists pay a lot of attention to as well. So let's look a little bit more at what CAT scans look like in ILD and scleroderma. So in this patient, so normal lung is supposed to be nice and black like this. When we see whiteness in the lung, that's not typical. So this patient, first off, has a dilated esophagus, which is very common in scleroderma, as all you know that there's a lot of GI involvement and especially a lot of heartburn in scleroderma. So this is one of the things that we see on folks with scleroderma's CAT scans, that they have what we call a patchless esophagus, meaning it doesn't close as it should. And then this, on both sides, we see this whiteness, and that this is the interstitial lung disease in scleroderma that we see. And this person actually has some fluid in their lungs as well, which is not necessarily typical in ILD or scleroderma ILD, but this person does have that, and they also have an enlarged heart. And then here are some more pictures of scleroderma ILD, where we see, again, it's supposed to be pretty dark and black, where we don't have that nice dark black lung. We see this reticular pattern here, and then we're starting to see some widening of the airways as well. And then this is progression of this. And then we also see, again, some fluid down here, which all of these are very common in interstitial lung disease. And then I wanted to show you what this disease looks like on pathology. So like when we take a biopsy and get a sample of the lung, what does it look like? This is normal lung here on the left, and you can see how thin the alveoli are. So they're very, very thin because we want gas to go across. But in scleroderma ILD, you actually have lots of inflammation. So that's the purple stuff here. That's inflammation that we see. And that's pretty typical for this thing that we call nonspecific interstitial pneumonia, NSIP. So all of this purple stuff is not supposed to be there necessarily. And then again, another biopsy that shows scleroderma associated ILD. And then you have, this shows better the collagen, the thickening here that you see. This pink is not supposed to be like this. Again, we're supposed to have a very, very thin alveoli and gas exchange surface, but we are just chock full of collagen and then also a lot of inflammatory cells. So those are the little purple cells. Those are not supposed to be there like that. So again, this is pretty common for non-specific interstitial pneumonia, which is kind of a broad category, but this is common in scleroderma ILD. This is a very busy slide, but I just wanted to show you how pulmonologists and rheumatologists think about ILD. So talking back, like we said, about what are the environmental risk factors that somebody has that maybe set off a cascade of something going on in their lungs, or something in their immune system that started off and started to cause inflammation. So this is one form of inflammation, it's called a granuloma, and then leading to chronic inflammation, and then going down into the kind of this is late phase, where you start to have what we call self-perpetuating fibrosis, where you have like more and more scars that just keep forming. So this is important to us as rheumatologists and then pulmonologists, also very important, because it helps us figure out like where are patients at in their disease. Are they in this early phase where they may respond super well to our medications that decrease this inflammation, or in the later phase where we maybe need a medication to deal with this fibrosis or this lung scarring. So this is something that we'll talk about a little bit more in a few slides. So treatment of scleroderma ILD. How do we decide whom to treat? So those patients with worsening lung function, or worsening imaging, or worsening symptoms. And sometimes it's a combination of all three. And again, this is patient to patient dependent, because there are a lot of complications that go along with scleroderma, and then patient preference is really important. So if the patient doesn't want to be on any more medication, then we're not going to throw more medication at them, because they're ultimately the person who has to take that medication. So treatment options. As you all know, there's no cure for scleroderma or for scleroderma ILD, but we do have treatments available. So first off, how do we treat ILD? First off, if we need oxygen, we give them oxygen. Pulmonary rehab is very helpful as well, and our pulmonologists usually prescribe that. And then medications, and then ultimately lung transplants. So let's talk about some of the treatment options that we have. First off, we have steroids, which are usually we use a drug called prednisone, but we have by mouth and also by IV. There is a chemotherapy drug called cyclophosphamide or Cytoxan. There's pills called mycophenolate mofetil, mycophenolate sodium, azathioprine, rituximab, and then just over the past few months, another drug called tocilizumab. And so these drugs can be helpful in the treatment of interstitial lung disease. These are not like one size fits all, that one drug is the best. And so it's really important that you talk to your doctor about which drug may be best for you. And then these are newer drugs that are on the block to help slow lung damage. So this is particularly helpful in those patients who have kind of the later form of this disease, where you have a lot of lung scarring that just keeps occurring. And so there's a new drug called nintedanib that we use in some of the other diseases from ILD. And now we're starting to use in scleroderma ILD. And now there's another study for a new drug called pirfenidone that's ongoing right now in the scleroderma lung study 3. And then as far as other things that are important to address, as I showed you guys, the esophagus gets really dilated and you can have a lot of reflux. And that is really important to treat because that reflux, you could imagine, can actually go into your lungs. So that's why rheumatologists and pulmonologists are really on top of treating that reflux, because that reflux could cause more damage and more scarring. So that's what we want to involve the gastroenterologist, and then making sure that we have that acid under control with the medication. These are the references that I have, and then how to get in touch with us. So if, we are Scleroderma Foundation designated Scleroderma Research and Treatment Center. So to see one of the pulmonologists or myself, we, a doctor or whomever refers to the Center for Lung and Breathing. Here's our website, and then our phone number is here. We are doing some research in scleroderma lung disease. That's that pirfenidone drug that we were talking about, that Dr. Joyce Lee is heading up right now. So with that, I can take any more questions that you have.
Thank you, Dr. Griffith. We do not have, let me see. We have a question that came in. So your research is for patients who have had ILD for a while?
So the one that's happening right now, it's folks who have scleroderma lung disease, and I think there are some caveats about like how long they've been on certain medications. So but we can help figure that out if you're interested. You can just get in touch with me.
Okay, and another question is, what? It's scrolling so fast. The person is asking, I have scleroderma and PAH and have been tested for ILD and don't have it. Should I be tested yearly for ILD?
So we usually, it's part of the thing that, Dr. Bull and I were talking about, is that, we get echoes, and then I also get these PFTs on patients mostly annually because I don't want to miss the ILD developing. There's not really a standard out there, but since I see all the patients that have ILD, I tend to be a little bit more aggressive on doing the PFTs yearly. It doesn't mean you need a CAT scan yearly, but because we don't want to expose you to unnecessary radiation, but doing some brief lung function tests can be helpful.
All right, and you had a number posted, and I guess if they're interested in your study, would you ask them to call that number that was listed?
Maybe let me get you the research coordinator. I can maybe email you guys her contact, and you can send it out.
Okay.
That way you can have, this is the main clinic line, and so they're not going to know what to do.
All right, and then the question is, what is CFTP?
What? Let me just look at CFTP. Did I have that on one of my slides? Did I miss?
I don't know where that came from.
There's an entity called Combined Pulmonary Fibrosis and Emphysema, which has got a slightly different acronym than CFTP, which I'm not sure if you're referring to the slide, but that's CPFE, which is something that actually causes significant pulmonary hypertension. It's both interstitial lung disease and emphysema, or COPD. But not sure if that's what the question's about. So I'm not sure what CFTP would be.
Oh, someone is saying they think they heard
PFT.
PFT, which is the pulmonary function test.
Yes, exactly, pulmonary function test.
Right.
So the other, she said, you mentioned another test you do annually. So the echocardiogram and then the pulmonary function test are generally what I do annually to screen for both the pulmonary hypertension and the interstitial lung disease. And then if you have the interstitial lung disease, we do other things more frequently.
And another question being asked is, can a patient with ILD survive COVID?
Yeah, I mean, in our clinic, we haven't had anybody get it, thankfully, yet, but you are technically a high-risk person. So we're suggesting that patients, socially distance as much as possible who have ILD, because any chronic lung disease puts you at higher risk. But it doesn't mean that having COVID is a life sentence by any stretch of the imagination. It just means that you're higher risk for hospitalization and having lung complications from it. So, that's why we're really worried about our patients who have ILD, so that we're advising them to socially distance, washing their hands all the time, as much as possible. We can get them keep them safe.
Let me see. There was another question that Dr. Bull did answer, but just so that everyone is aware of it. Is there anything you can do to prevent pulmonary hypertension from developing? Dr. Bull, would you like to address that?
Yeah, sure. And so I typed a message to that, but it's at this juncture, we do not have a preventative treatment strategy. What we do have is kind of what Melissa was just getting at, is a screening program, because we do have studies, one study in particular called the EARLY study, which demonstrated that if we treat pulmonary hypertension patients early, they do better than if we're delayed in the diagnosis, hence the concept for screening. And, scleroderma happens to be, again, a disease that's got a high prevalence of pulmonary hypertension, depending on, what the study you read. It's anywhere from like 5 to 15% of patients with scleroderma, especially limited systemic sclerosis, at risk for the development of pulmonary hypertension. So it does put us in a group that we can then do screening, like Melissa was saying. Echoes, actually the PFTs, I'm remiss in mentioning that. That's actually a better screening study for us for scleroderma, for PH as well, because something called the DLCO, or diffusing capacity of carbon monoxide, which is how well gases cross the alveolar membrane, drops earlier than the echo changes. So if we see a drop in the DLCO, that prompts us to both echo and then go to the cath lab. So it's really our strategy now is to screen and try to catch it early. Prevention is a goal, and that's where I kind of alluded to that in my talk. I think that's where we're going to be going, because a lot of the drugs that we're looking at now are really more focused at preventing that cell proliferation. So I think that's the here, I had my video off. That's the future coming forward. So look to that. Once we have drugs that we've demonstrated actually prevent it or regress it, then the obvious extension of that would be taking at-risk individuals and putting them on it early to see if we could prevent it. That's a harder bar to hit, but it's certainly our goal to get to. And that's where we would turn to Melissa and say, okay, within your group of patients, who is the really high risk? And she has some ways of screening for that with antibodies to kind of tell us who that population might be. So look for that sometime down the road here.
Thank you. For Dr. Griffith, how long have you been involved with scleroderma patients?
So this is like my 5th year of being involved with scleroderma patients. And I learned under Dr. Fisher when I was a fellow here. So learned from the best as far as rheumatology goes. And still, I mean, every day is, I think I learn more and more. And I think my patients probably teach me the most because they have all been living with this disease for so long. But continuing to learn and loving it here at the University of Colorado.
Another question that was asked is low or fast or irregular heartbeat common in PHT or ILD?
So from a pulmonary hypertension standpoint, when pulmonary hypertension becomes more severe, kind of longer standing, our patients are at risk for dysrhythmias, arrhythmias, in particular atrial fibrillation and atrial flutter, which is an irregular heartbeat initiating from the top part of the heart, the atria. We don't generally see it early on. It usually is patients that we've known have had pulmonary hypertension for a while. The right atrium starts to dilate because of the pressure, and when it dilates, it alters the conduction system. And then, really in ILD, there are a couple of atrial tachycardia, something called multifocal atrial tach that occurs in patients when we're not dealing with their oxygen very well. Is kind of the main problem that we see from a cardiovascular standpoint.
All right. We have time for a couple more questions. If anyone has anything, please post it in the chat.
I saw someone had posted a chat on exercise-induced pH, and then I was trying to answer it and I erased it. My apologies. There was a question: how does exercise-induced pulmonary hypertension kind of fit into our paradigm here? So that's actually a very controversial area as well. Exercise-induced pH is just what it sounds like. So your pressures might be at normal at rest, but when you exert, the pressures go up as your cardiac output increases. And I personally, with the problem that we have to why it's controversial is we as a medical community cannot come to an agreement on what the definition of exercise-induced pulmonary hypertension is. What is the hemodynamic definition? So we argue about this a lot. I'm a big believer, I think most people that do heart caths, is that there is a definition, meaning that there is an abnormal response, and I have a personal bias as to how we define that, and I think a lot of the people in the world who do the cath parts of it do as well, but we just haven't kind of pushed it through as a group yet to what that is. Why that's important, though, a good question for scleroderma is that I just mentioned that screening and trying to pick up the disease early is a goal, and so exercise is a way to try to do that, and that's not exactly rocket science. We do that, for example, in coronary disease. Like if we think someone has a blockage of a coronary artery, we put them on a treadmill and we make them run or ask them to run, and then we try to evoke the symptoms by having them run. So I do the same thing in our cath lab, a little bit different. We put a heart cath in and put people on a bike with the heart cath actually in. It's a little bit of a dance to kind of get up on the bike once we got the heart cath in, and then have the individual pedal while I'm measuring pressures directly. And then the tricky part becomes what is the cut point? But I have what I look at is what's called the cardiac output to pressure slope, and I look at the slope to make that determination. And the next point is if you find that abnormality, then you have to convince an insurance company to pay for medications. But we have a couple of studies that we're working on that right now. So.
All right, one last question. Does living at a higher altitude put you at a higher risk for developing PAH?
Yeah, that is a great question. And I showed that picture of Mount Everest in my slides. And so if you get high enough and make your oxygen low enough, you will develop pulmonary hypertension. In fact, there may even be a component of altitude that's not exactly consistent with the hypoxia. And there is a disease called Monge's disease, M-O-N-G-E-S, which is altitude-associated pulmonary hypertension. So altitude can definitely result in pulmonary hypertension. Now, we think we can counter that by adding oxygen for most people. So, the problem, as you get higher, your partial pressure of oxygen drops because of the altitude. So the higher you go, the less oxygen there is, and hence why people get, hypoxic. And so we counter that by adding external oxygen. But we do have patients who opt to move because, oxygen is a bit of a, hindrance and opt to move to lower altitudes, sea level, to help to not have to use oxygen and then also to help deal with their pH. So altitude is a contributing factor. The higher you are, the higher the risk. Most of our patients don't move because moving, leaving family and that sort of thing is a difficult issue. We have one of the biggest pulmonary hypertension programs in the country. So most of our folks are not moving away, but one might wonder if altitude is playing a role in that too. That's actually, myself and my colleagues are kind of working on that. Dr. Badish just with a resident just published a study on sort of our incidence of altitude and its impact on heart caths. And we got another fellow working on a study right now with me at the moment. So an important area certainly for us.
Thank you both, Dr. Bull and Dr. Griffith, for joining us today and sharing your time. We really appreciate it.